Good morning, everybody. Thank you for joining today's session. So just before we start, just want to point out that I want you guys to just keep an eye out in the chat box. There'll be some links posted in there for a pre-assessment. And then towards the end of the session, there'll be the post-assessment and an evaluation form. Just make sure you complete all three of these documents, and this will help you to get your certificate at the end as well. So today's session is being presented by Leah. She's an orthoptist in Moorfields Eye Hospital, as well as the Nat Al Marat Hospital in Abu Dhabi. She graduated from the University of Liverpool in the UK in 2014, and she began working in Essex Hospital for about 2 years, and then moved on to Barts Health Hospital in London. Here, Leah was the lead for vision screening, as well as clinics for adults with learning disabilities. She joined Abu Dhabi in October of 2021. She has experience in working in a range of clinics, which include pediatrics, neuro-ophthalmology, adult motility, and special needs clinics. So today, Leah's presentation will be on strabismus. Leah, you can start.
Hi, good morning, everyone. Thank you to everyone for joining. Just going to share my screen. Okay, so thank you to Sonal for the introduction also. Yeah, I'll just get started. So I'm not sure how familiar anyone is with strabismus. I'm sure there's a few of us from Moorfields on this chat. So yes, it might be completely new. So I will hopefully cover the basis of strabismus and what there is to know about it. So let me get started with the objectives for this presentation. So very first and simply, I want to be able to define strabismus, as well as being able to understand it. We want to understand the difference between strabismus and what we'll soon know to be a pseudostrabismus. I want to be able to explain how to identify the different types of strabismus, as well as understanding how we test and diagnose the different types of strabismus through both orthoptic and ophthalmologic testing. And as well as that, we want to understand the treatment options that are also available for strabismus. Okay, so we'll start with what strabismus is. So very simply, it refers to the misalignment of the visual axis, which is the position of the eyes. It can often be referred to, particularly in clinic, as a squint, or sometimes a lazy eye, and it can occur in one or both eyes. And this is where the eyes can turn inwards, outwards, upwards, or downwards. So any direction. And if left untreated, it can affect the vision permanently, which is why we want to diagnose and manage it as early as possible, particularly in children as their visual development is happening. Okay, so when does it typically occur? So with congenital, so I'm basically broken it down to congenital and acquired. So basically with children who have strabismus, 50% of them are actually born with it, with the ones developing it a little bit later, which I'll go on to talk about later in the presentation. It's important to be aware that it is very normal for infants' eyes to change position and look as if they're not straight, but we do expect that to resolve around 3 to 4 months. So if these do still seem to persist and have a squint or a strabismus after 3 to 4 months, we would definitely recommend an assessment with an orthoptist and an ophthalmologist. So by that age, they should be able to focus on objects. So if it's not, if this squint doesn't develop at the congenital stage or when the baby is just born, the most common time for a squint to develop is from 18 months to around about 6 years, and that's to do with the focusing and the changing of what a child does with their vision and what's expected. The next is acquired. So that just means it develops a bit later on in life. So yeah, it's not present in childhood. So as I say, throughout the presentation, I will go through the different types of squint that we might expect in clinic. Okay, so looking at the prevalence and causes of strabismus in particularly children, first of all. So the prevalence range is quite a big range from 0.8% to 5.65%. That's come from a number of studies, which are outlined at the end of this presentation. So yeah, there's quite a wide range of studies available looking at different types of strabismus when they occur. And yeah, so that's sort of broken down to 0.8 to 5.65%. A lot of cases of strabismus are inherited. So as you can see here, it's about 30% of children actually have a family member who also have a similar problem. So that can be mother, father, close relatives. Other causes that aren't hereditary can be if the child has a need for glasses, so an uncorrected refractive error. So a refractive error is what we use for the term for needing glasses. If there's reduced vision in one eye, if there's binocular fusion abnormalities, which is a problem with using both eyes together, or any neural problems of the eye movements, which we'll cover a little bit later on. In some cases, you might remember at the beginning of the presentation, I mentioned about pseudostrabismus. So an infant or a young child kind of have the appearance of having a strabismus, when in fact the eyes are nice and they're straight, so they're not misaligned. And this is what's referred to as pseudostrabismus or a pseudo squint. So I'm actually going to talk a bit more about that. So I've got two images here. On the left-hand side, you will, so it's two, basically, first of all, you'll notice that there are two young children, two young babies. On the left image, you will see that the child has brown eyes. The child with brown eyes, there are two white dots in the middle of their pupil. So it's quite dark, but hopefully you can see that okay. Those white dots represent a light source. So normally we use a pen torch in this assessment, and you'll see that the light source of the white dots are reflecting symmetrically, so right in the middle of the pupil. So that's a test that we use to help us work out if the child has a strabismus or if it's not a true strabismus, in which case a pseudostrabismus. You'll notice as well that there's maybe less white visible on the child's left eye, so it's on the right hand side in the image, in the corner of the sort of the inside of the nasal part of the eye. So it's it looks like there's a squint, but when we use this light reflection, there's not a squint, so it's what we call a pseudostrabismus. On the second image, you'll see that there is the child has, well, they've actually got dilated pupils, so it's not as clear, but I wanted to use this example, as you can see very clearly that the child looks as if they have a big squint, so one eye is turned inwards, it's their right eye, but whereas in fact the child just has a lot of growth and changes to happen if they've got a flat nose bridge and what we call epicanthus, which is the skin that is sort of going to be used to build up the bridge of the nose, and it sits in the corner of the eyes, making it appear to have a strabismus when in fact it is not. So we normally will reassure the parents after an orthoptic assessment that we expect this to improve and change as the child gets older. But it is still important to remind the parent that, of course, that because there's not a squint now, doesn't rule out that that might be the case in the future. So it's important to book a follow-up appointment so that we can review them again when they're a bit older. Okay, so just touching on strabismus in adulthood. So I've just outlined a few points here, and it can be a strabismus in adult can be residual from a child or from childhood. where we normally see the patient present where they don't have any double vision. It may be a cosmetic thing, it may be something that other people have noticed, different symptoms that they might present with, but normally it's not associated with seeing double vision. With this, when we do see a patient who presents with double vision and it's a new onset squint, we might think, why is this happening? We might want to do some further investigation beyond ophthalmology and orthoptics to find out where this has come from. But of course, if they're presented in the eye clinic, we will do everything we need to do first of all. It can be a result of many different things, such as nerve palsies, thyroid eye disease, just amongst some things that might be the cause for the squint, which is important, which is why it's important for further investigation if clinically indicated. Final point on this side. So in some cases it because as a result of aging, so the soft tissue that surrounds the eyes and the muscles around the eyes can change as you become older, and that can result in a DVS, a strabismus or a squint. Okay. So just on that, I just wanted to do a brief sort of summary of basically how the eyes move and the muscles around the eyes. So we have 6 muscles surrounding the eye, 7 if we include the muscle that moves the eyelid, but this is just covering the 6 extraocular muscles that are involved with the eye movement. We have 3 important nerves that control the muscles and or supply the muscle with their innervation to move. So I've outlined their what they do and how they move the eye. They all have a different job, and these are very important, particularly when we are assessing a patient with a squint, so we can work out which muscle is causing the problem, and particularly if we're deciding to do some treatment or management, it's important that we can work out what the cause, what we can do to help. So just if you'll see there's the names of the muscles, which I have again just outlined on the next slide, and which nerve supplies them. They're also their functions, they all have a different function. Some of them have 3 functions, as you can see outlined on the slide. And I thought it was quite useful to have how we actually test that muscle and their movement. So yes, you can read that on the slide there. Okay, so talking about the muscles, then I wanted to go on to the different types of deviation. So deviation is where we can use to describe a squint or strabismus. So I've broken it down to the 2 different types that we see. So we have a heterotropia. So that is what defines a squint that we can see when both eyes are open. So you might notice, as I've said, I mentioned earlier before, that the eye may turn inwards, outwards, upwards, or downwards. So you can see that generally speaking when both eyes are open. The other side of it is a heterophoria, which is what we call a latent deviation. So that is not very obvious to the naked, like when you're just looking at a patient, you generally won't see, or you won't see that when both eyes are open. You'll need to do some further tests, and normally with an orthoptist, to discover if there's a latent deviation. Now the patient may still have symptoms, as sometimes these latent deviations cause some trouble, particularly if tired or for different reasons, but generally you won't notice it when both eyes are open. So I've got some useful pictures that might help clarify that, because it's not always the easiest to explain. So I found this image online and I thought it was quite useful. If you look at the top picture, it's just the eyes straight ahead. They're looking at, there's no sign of a squint at the top image. So the second image below that is, so there's a sort of grayed out circle, and there's then under that circle, you'll see that eye is turned inwards. So that grayed out circle is representing an occluder, which some of you may know, hopefully you do. That's what we use in clinic to help us assess for a squint. So whenever that eye is covered, that's when you will see the eye turn inwards. So that's what we call a latent strabismus. So I'd say whenever that that grey circle, so the occluder is lifted away, the eyes will become straight. So that's how we can pick that up. So I'll just show you the difference. So this was before the heterophoria. This is when we have the heterotropia or strabismus. So I thought, I always like using this image. I've used this one before, and people have mentioned that it's quite useful to, it makes things a bit easier to understand. You will see in the image, so the patient's left eye, or on the right hand side of this image, is the eye, that's their fixing eye, so that's the eye they use, or they're looking straight ahead. The other eye, so their patient's right eye, which is on the left side of the image, that is demonstrating the type of strabismus that is present. So the first image you will see is an esotropia, which I've explained is turning inwards, exotropia, outwards, hypertropia, upwards, and hypotropia is downwards. So there's lots of different ways you can use to, or you can remember these types of strabismus and their names. But it's quite nice to have this image to sort of help understand it. So there's different sort of classifications that we can go further to break to sort of with the classification. There is I'm going to go into ones that we most commonly see in clinic, and I'm fixating on and focusing on esotropia and exotropia today. So first up is the esotropia. So there's quite a lot of information on the slide, I understand that, but I'm just going to focus on one type of squint that, as I've said, is most commonly seen in clinic. So you'll see that esotropia is in the middle. It can be broken down into whether it's constant or intermittent. So it's very simple in that if it's constant, it is there all of the time. So the eye will be turned inwards, whether it's with glasses, without glasses, a very slightly turned inwards, or quite significantly turned inwards. There's lots of different types there that we can see, but I'm not focusing on them today. On the right hand side, you'll see there's intermittent. So again, that's there sometimes, sometimes not. I want to look a bit closer at accommodative. So further on from intermittent, you'll see there's accommodative, and we have a fully accommodative esotropia, which I will present to you on the next slide. And this is what we see. So this is a picture. It's a great picture to represent what a fully accommodative esotropia represents. The child doesn't seem too happy about it, but anyway. On the right hand side, or the left hand side of the image, you will see the child not wearing glasses, and the patient's right eye, so on the left hand side, looks left hand on the picture, this eye is turned inwards. And you can also see that, as I mentioned before, about shining the white dot. So it's obviously a pen torch that's been used. The reflection of the patient's left eye is right in the middle of the pupil, whereas in the patient's right eye, it's a bit more temporal. So it's on the outside of the pupil and the iris. So that's representing an esotropia. You'll see then when the child has the glasses on, the corneal reflection, so the white dot is right in the middle of both eyes, and that's what we call a fully accommodative esotropia. And I'm going to talk about what tests we need to do to get to this point in this diagnosis. As you've seen, there are quite a lot of esotropias that we have to differentiate from. So the diagnosis of that comes from different clinical tests with an orthoptist. So with the fully accommodative, I just wanted to also touch on a different type of accommodative squint. And this is our partially accommodative. So they're quite similar, and again, they need further testing in clinic to sort of differentially diagnose. So this child, you will see again, it's the opposite eye that she has an esotropia in. So it's the left esotropia. You will be able to see the light that's been shown, and the patient's left eye, the reflection is falling temporally. And whenever she puts the glasses on, you can still see that the corneal reflections aren't quite symmetrical at all, but it's definitely quite a bit better. So that's sort of, these are two types of esotropia that we commonly see in clinic, and are greatly helped with the use of glasses. As I say, I'm going to touch on what other tests we might do to differentially diagnose from this type of squint. Okay, so now I want to cover exotropia. So this is the deviation that drifts outwards. So again, this is a similar diagram that I've used for differentially diagnosing and what types of exotropias there are. So again, I'm focusing on one type of the exotropia that we will most commonly see in clinic. So again, just before I get into that, you can see from the diagram here that the exotropia can be broken down to constant or intermittent. Constant again is the one that we see that is present all of the time, so constantly. Intermittent is when it's there sometimes, when it's not there other times. So the one that I'm going to focus on today is the distance exotropia. So quite simply, it's exotropia in the distance, but at near, there's normally no strabismus. That can be broken down further into true or simulated, which is very important, particularly if we're going to consider some particularly surgical management. So yes, and we can differentiate between these different types through orthoptic and ophthalmological testing. So I'll show you a picture of what we expect with an intermittent distance exotropia. So this is a little girl. The first image on the left-hand side, you'll see that the patient's right eye is drifting outwards, where the left eye is straight. This is the child looking at a picture in the distance, so that's normally around 6 meters away. And on the right image, the child is focusing on an image around about sort of 1/3 of a meter. And that's where there's no sign of a strabismus. And you can see that, again, bringing back to the white circles, which represent the light source, normally a pen torch. You can see that her corneal reflections are symmetrical in the right-hand image. On the left-hand image, you can see that in the left eye, the corneal reflection is right in the middle of the pupil. The right eye, it's more nasal, so that's where you can see the eye drifting out. But also you can see you don't really need to use the light source for that kind of squint. Okay, so after the classification of the different types of squints that we are focusing on today, I wanted to sort of go over what we would talk about in clinic, or what tests we would need to do in clinic, and how we get to the diagnosis. So first of all, the most important thing to begin with is a good and clear case history. Particularly if this is a new patient, you'll assume the patient is brand new, you've never seen them before. You want to know everything about them and how we're going to get to the bottom, or how we're going to get to the diagnosis and come up with a management plan. So it's important. I've outlined everything that we would talk about here. So the birth history, or the premature, is there any history of forceps use or a C-section, dependent as well on the age of the child or the age of the patient. You want to know about their general health, their family history. As I've mentioned before, there's a large percentage of patients will have a squint if a family member has one or something similar as well. You want to know how old was the patient whenever they started noticing the squint or any problems like this. What direction is the eye moving? Is the eye drifting outwards, upwards, downwards, inwards? Is it there all of the time or only some of the time? And is there any other associated signs or symptoms, such as double vision or blurred vision, or anything that they might mention? Their headaches as well. Another key thing in clinic that you might want to document is just making a general observation of the patient. So have they walked into your room? Are they in a wheelchair? Are they using aids for their, how they present with themselves? Are they using a head posture? So they might be holding their head in a particular position. With that, I'll just briefly mention that some patients who hold a head posture have an imbalance with their eye movements. We do see that in some patients, so it's worth documenting if you notice that before doing any further assessment. I mentioned before about the pseudo-strabismus or pseudo-squint, that this type of squint can be very common on children who have a very flat nose bridge, or have the skin folds that are going to be used to build up the bridge of the nose, and that's referred to as epicanthus. You also want to document any maybe craniofacial abnormalities, or anything else that you think would be relevant for your testing. But also just use the information that the patient gives you to sort of help you with your assessment. So we'll go into the clinical assessment. So visual assessment is key in it's what we, it must be done on every patient that we've seen. I'm not going to go into too much information on this, as Sonal, my colleague, covered this a few weeks ago in her CME talk, and also Dr. Omar covered amblyopia not so long ago, so I'm not going to go into too much about vision assessment. So it's just important to outline that it must be done, particularly in a patient who has presented, who presented the eye hospital. So again, I've not stopped to mention about corneal reflections. So that's a very simple way to start the assessment, particularly if it's a young baby or a child. You just literally shine the pen torch in their eye to see, are their corneal reflections symmetrical? So this diagram sort of outlines, so you'll see a normal corneal reflex or corneal reflection. By normal, it's more so just that they're symmetrical. We don't always like to use the word normal, but they're symmetrical. The esotropia, where the eye is turned inward, you'll see that the reflection is a bit more temporal. So yes, it's a nice way to sort of quickly start off an assessment with any patient, but generally you can use it with children if they're young babies. And also with the last image there, as I've mentioned earlier, with the pseudo-strabismus, you'll see the epicanthus, which can give the appearance of a squint, but you'll see that the corneal reflections are symmetrical. Okay, so there's a lot of information on the slide. We can see that, but it's basically just, these are the tests that we use in orthoptics. To be honest, I think it'd be worth doing another presentation at some point to outline what the orthoptic assessment involves in a bit more detail, because it requires a bit more time. The orthoptic assessment that we use generally was to sort of diagnose a squint, measure it, work out is it constant or intermittent, and any other tests that are relevant to decide on a management plan. So I've outlined here the cover test that we use to discover what type of squint is present. Is it a manifest strabismus, which is the strabismus that you see generally when both eyes are open, or is it the latent type of strabismus where it's a little harder to find, but you'll need to do this cover test to work out which type it is. You'll want to assess that at near and distance, and also measure it, which is what we use the prism cover test for. So by measuring it, you are essentially measuring how far the eye is drifting outwards, inwards, upwards, or downwards, which is essential for a management plan. Binocular vision assessment. So binocular vision is the ability to use the eyes as a pair. There are 3 different levels of assessment for binocular vision. So it's important that we check each level, as you want to make sure, or to work out the strength of their binocular vision. And as I said, there's different tests that we can use to work that out depending on patient's age, ability, and essentially what you're testing. Ocular motility is what we use to check eye movements and to see which muscles might be causing a problem. And that's generally done with using a pen torch. And it's, as I mentioned before about the eye movements, you move your eyes into different positions to check that the muscle is doing what it should be. Convergence is the type of eye movement that we use to bring your eyes in towards your nose and relax them out. So you want to check, make sure everything's okay with that. And then you'll decide if there's any other orthoptic tests that might be relevant, depending on the patient, their age, and what they have presented with. You'll also need to decide what further tests are required after, and if there's anything more than orthoptics needed. So, which I've covered on the next slide. So following an orthoptic assessment, depending on what you find, you might want to do a glasses test or a cycloplegic refraction. So a refraction is essentially assessing for if there is a need for glasses, and it is very important, particularly with new patients that might present with a squint or reduced vision. So we have optometrists who do that for us. You can use, so cycloplegic means that we use an eye drop to dilate the pupil. So that's very commonly used, and also with dilating the pupil, you can also check the back of the eye and get a good look and make sure everything is healthy and developing as it should be. And it's important to rule out any pathology that might be causing a strabismus. So yes, that's generally what we'll decide to do in clinic, and that decision is made based on vision and assessment for a squint. Following refraction and dilated fundus immediate check. So the fundus immediate check is what we use to refer to checking the back of the eye and the health inside the eye. So following that assessment, depending on what's found, we might want to consider doing any further investigation, which might require referring to another service. So yeah, that's to be considered following a clinical assessment. So once we've done all this clinical assessment and we've been able to diagnose the type of strabismus and advise or given our opinion and advice, following the decision that's made, it's important to remind the patient that they will need to attend follow-up appointments. And this is just to ensure that, first of all, if it's a new onset strabismus, we want to ensure, is that staying stable, is that changing? And particularly if they want to have some treatment other than maybe glasses or whatever, we will need to see them at their follow-up appointments. So yeah, that's a big key thing so we can ensure good visual development, particularly in children, and also if they want treatment, so we can make sure that we can offer them the best to ensure that if there is anything changing with the squint or the eye movements, that we can monitor that. Okay, so again, this is another slide where there's quite a lot of information, but this is the management or how the management how we would approach management in both children and adults. So as I've said, we will need to do all of these clinical tests to sort of come to the diagnosis, in our opinion. You'll want to treat any amblyopia if there is any, particularly in a child. So that's and as I said, I'm not going to go into too much detail as this has already been covered by Dr. Omar. So amblyopia, just if there's reduced vision in one or both eyes, you'll need to treat that first of all to ensure good and normal visual development. Correct, if they need glasses, you want to give them some glasses. You want to ensure that if the squint is present, is that changing all the time? Is it staying stable? That's why the follow-up appointments are important. BSB potential, now that refers to the binocular vision that I've mentioned before with the test, and so that's very important, particularly if you're deciding to do any surgical management. You want to see, is that going to sort of, do they have the potential to use their eyes together as a pair? Is there no potential? Are they using their eyes as a pair? That's where clinical assessment helps us. And finally, are we going to do some surgery on them? If so, what can we do? What type of surgery is available? But lots has to be considered, such as the patient, like what I've just mentioned about treating everything else, but also the child's age, things like that, and obviously the parents, you'll need to discuss with the parents what they want. So somebody with an adult, you're sort of working out what the best management plan, but you do need to treat sort of work out what's causing the squint. Is it from childhood? Is it something that's new? We need to work out where that's come from. And have they had maybe some surgery before on their eyes? Is that going to impact what we decide to do? Again, with the adult, we want to ensure that the squint is stable, so a follow-up appointment is very important with that. Do they need glasses? As I said, similar sort of situation with the child, and also are we going to decide to do some surgery? And if so, what type of surgery is available for them. So I've just wanted to show examples of the types of surgery that we can offer, what types of management. So generally with like doing a squint surgery or a surgery for strabismus, it's important that everything is treated before, as I can't emphasize that enough. So as I've outlined here. So we will decide to do surgery after we've treated everything else and discussed it with the family. If a child, obviously clarifying with the parents, and with an adult, will be, everything that the cause will be worked out and treated, and it'll be decided over time. So I just wanted to show what surgery leads to. So this is a case of Dr. Saeed. This is a child, the first image is the child before the surgery. So you'll see that they have an exotropia. So yeah, as I say, just before surgery, the patient's right eye is drifting outwards. This second image was 1 week post-op or post-surgery. So the eyes are nice and straight. So you can see, again, I've used the corneal reflections, you can see that they're nice and symmetrical. So that's a really good example of what surgical management can lead to. So yes, this patient does not require glasses. They'd had any other previous treatment had been completed, and the squint had been stable for some time before this surgery was carried out. So that's quite a nice example to see sort of clearly. So, it's hard sometimes to explain what surgery of the eye muscles involves. Generally, people get a bit nervous with the idea of having surgery on their eyes. So this sort of gives you an idea of what happened. Like, I'm obviously not going into detail about the actual surgery, but this is the outcome that we do see from strabismus surgery. This is another example of a young child who has had strabismus surgery for an esotropia. So the first image on the left-hand side, you'll see the child's right eye is turned inwards, looking at the corneal reflections. The left eye is nice in the middle of the pupil. In the right eye, it's a bit more temporal. So you'll see the image on the top. So he's had the surgery. So this would have been fairly soon after the surgery. So this is 1 to 2 days post-op. Still a bit red, so that will just be residual from surgery. It's not bleeding, it's just a little bit of it's just a bit of residual from the surgery. So the eyes, even just after the surgery, are nice and straight. And then the bottom picture on the right hand side is 1 month post surgery, and as you can see, the eyes are lovely and straight there. So that's another example of fabulous surgical outcome. So these are Dr. Saeed's patients. So yes, as I say, lovely example of strabismus surgery outcome. So that concludes my talk about strabismus and what we and as finishing on the strabismus surgical outcomes. So I did want to try and make this a bit more interactive, as I know I've been talking for quite some time. So I know I've been speaking a lot about corneal reflections and things like that. So I wanted to bring it back and hopefully get some people involved, if anyone wouldn't mind. So the next slide I want to show you is this child. If anyone wants to join in and maybe have a go and let me know what you think. Is that a strabismus or a pseudostrabismus, and why you would think that? Anyone's there?
There's a few people in the chat box saying pseudostrabismus.
Brilliant. And does anyone want to have a go, or does anyone want to mention why it's pseudostrabismus?
Hani Din says corneal reflections are symmetrical.
Perfect. Exactly. Thank you.
Dr. Anusha as well.
Brilliant. Thank you. Exactly. So the corneal reflections are symmetrical here. So yes, and you can see that the child has, as I mentioned before, the flat nose bridge and the sort of the sign of epicanthal fold, which is the skin, the corner of the eyes. So I will show you another one. So again, if you want to write in the chat box or have a shout out. And Yeah, same again, you'll see the corneal flexion. I know the image isn't as clear, but hopefully you can see, on my side, you can kind of see the pupils. So if you can write in the chat box and let me know what you think. If it's
So a
strabismus.
few people have said esotropia, strabismus, RET, strabismus, esotropia.
Brilliant. Yeah,
People.
so yeah, perfect. That is great. Exactly. So yeah, that's a definite right esotropia this patient has. From even just, you don't really, like, the corneal reflections are perfect to show us that the light is following temporarily. But yeah, you can see there that that right eye is turning inwards. So yes, brilliant. Thank you very much. So that wraps up my presentation. So I don't know if anyone has any questions. I should hopefully be able to answer. But yeah, that's me.
So if anybody does have any questions, feel free to put them in the chat box or unmute yourself and you can ask them to Leah directly. So Leah, I'll just ask you one quick question.
Sure.
To kick things off. You mentioned strabismus treatment being surgery.
Yeah.
Would you say there are other ways you can treat strabismus successfully?
Yes. So with strabismus, so it depends on the type of strabismus that the patient might have. You want to, as I've said, you can use glasses in many different types, like such as the accommodative esotropia. Also as well, strabismus now would be sort of the last decision we made. We might try, particularly in adults, if the patient is symptomatic with double vision, for example, we can use prisms. Or in some cases as well, we can use botulinum toxin, also known as Botox, depending again on the type of squint that the patient has. That can sometimes be an option. So yes, it's not just surgery. I probably didn't clarify that enough, but it's not just surgery that we can use for the treatment of strabismus. But it is an option in many different types of strabismus. Do you have anything else to add, Sonal?
No, I think you've covered it. So exercises in certain cases, prisms, like you said, to treat the double vision more so than the actual drifting of the eye, and Botox, definitely. So there are other ways to treat it other than surgery, and surgery being the sort of the last resort.
Exactly. Yeah.
There's a few questions in the chat box. Do you want me to read them out?
Hold on, I'm going to stop sharing my screen. Or actually, oh no, I can get the chat here. You mentioned acquired can reduce. So I've got Lauren. Hold on, I'll go back. Is that the first? Hold on. Sorry,
there's one by Pooja Kulani.
Okay. In case of sudden onset ET and hyperopia of +4 cyclo, is MRI necessary? Is this patient a child or an adult? Pooja?
Hello.
Hi, Pooja.
Yeah. This is Pooja, right? It's child of 2 years. 2 years.
A child. Okay. Have they had an ophthalmologist, like an orthoptic and ophthalmology assessment?
Yes, I am a pediatric ophthalmologist, so I had done the retinoscopy, and I got the value of +4 cyclorefraction.
Okay. And how old is the child?
2 years old.
2 years old. So I mean, assuming that you've done the full, excuse me, the full fundus and media and cyclorefraction, MRI wouldn't always be necessary, because at 2 years old, it is quite common for particularly a child of that age to develop, like that's a common age for this type of esotropia to develop. And by this type, I mean an accommodative type. So have you seen the child at a follow-up appointment, or is this someone that have you prescribed the glasses?
Yeah, I have prescribed glasses and asked them to review after 2 months. So
I think I would think that's completely appropriate, and if they come back and you see that maybe the squint is an accommodative, where you would see the esotropia become less with or completely resolved with the glasses, then again, it would sort of confirm that MRI is not necessary. But it's not, this type of squint is it's quite common, as I've mentioned during the chat, it's quite common for particularly an accommodative type of squint to develop at this age. And given that it's a +4 cyclo, which is sort of higher than we expect in a child without a squint at the age of 2, I wouldn't say an MRI is clinically necessary.
Okay.
And that's in my opinion, so unless anyone else is on here. But if you, yeah. But,
Okay. But if I get the value of +2, say +2 or +2.5, then what should I go like for?
For this type of child, particularly presented with an esotropia and found to be hypermetropic, I would give their full prescription, just because of the esotropia, because if it is an accommodative, you want to give them their full prescription. And also their visual acuity. Did you assess their visual acuity?
No, the child was not that cooperative. He was not cooperative.
Okay, but I still based on the level of the hypermetropia and as well the fact that they have an esotropia, I would definitely give the full prescription.
Okay, yeah, thank you so much.
No problem, Pooja. Good luck with that one.
Thank you. Okay.
Okay, so the next one was...
The next is from Lauren.
Lauren. Oh yeah, you mentioned acquired space can be due to stroke, tumor, etc. Can TBI cause that, or is it mostly double vision with ocular lobe aspects? I think with this one, it can't, like, I think further investigation is needed for that one. I wouldn't be confident to answer that one on this chat. I think they would need further clinical investigation. So in terms of that, like with TBI, they're going to need an MRI anyway. So if the patient is getting double vision, they would need an ophthalmological and orthoptic assessment if double vision is the problem. So if that is a patient that you're seeing, I would recommend that you refer to ophthalmology and orthoptics if they are experiencing double vision. So yeah, I wouldn't be confident enough to comment on that particular patient. Sonal, I don't know if you would agree with that. There, anyway. So I'll move on to, I think that's all the questions.
If you have any more questions, please post it in the chat box, or you can unmute yourself and ask Leah. At the same time, kindly complete the post-lecture and the evaluation surveys posted in the chat box.
Thank you everybody for joining today's session. I hope you've enjoyed it and found it really interesting. Like Annette said, please make sure you've completed all 3 survey links, and soon you'll be receiving an email in how to apply for your certificates on the TAM website. So this will be in an email detailed on how to do this. Thank you again, and thank you, Leah.
Thank you, and thank you everyone for attending.